Recording in progress.
You would have in your inboxes and on the various platforms assessment forms for us to be able to review from January till now the CPDs we've done and how we can improve upon them so that next year's CPD will be better than this year's. We will also bring forms around to ask your input in the various topics you would want us to have for next year as well. So once again, thank you so much. Thank you all very, very, very much for your cooperation, your commitment, and your participation. Right. So today is this topic is a very important and crucial topic for assessment, anthropometrical assessment for our clients in the hospital. They serve a very key, especially for the very sick when they are in bed, and we have to meet them at their point of nutritional deficiency. This assessment technique is very, very important for the practitioner. So we have an experienced dietitian and who has been using this technique also in his practice to lead us in this discussion. I believe that we will enjoy ourselves as always, and we'll end with a lot of insight to carry along. So our speaker is Mr. Maxwell Bisala Konla, a registered dietitian and Master of Public Health holder. His profile. So Maxwell Bisala Konla is a senior dietitian. Let me, please just pardon me. Let me make sure that everything is clear so that all of us will see it clearly. Good. Then, right. Yeah, so Maxwell Bisala Konla is a senior dietitian at the University of Ghana Hospital. He has a background in dietetics and Master of Public Health from the University of Ghana with 8 years working experience. He's also a nutrition consultant for Executive Heart Center, E&E, Medical Center, E&E Medical Center, Sonia Nabita Foundation, Ashesi University Health Center, and a part-time lecturer at Oak City Nursing School. So Maxwell is a young, enthusiastic professional that this one you will know very soon as he starts talking, who is committed to improving the lives of people through health promotion and education. His interest in improving food environment has inspired him to partner with Tasty Treats Ghana. Tasty Treats Ghana is in the University of Ghana campus, at Noguchi to be precise, one of the biggest food services or food service companies in the University of Ghana, to set up a special diet services which provides healthy meal alternatives to people who want to eat healthy or live, who want to live healthy, or people living with chronic diseases as well. Maxwell is also a public health nutrition researcher who is currently working with a team of other researchers from the University of Ghana School of Public Health to evaluate the World Bank improved feeding practices in the first 1,000 days across 3 districts, Kintampo North, Setre East, and Kassina Nankana in Ghana. RD Max has vast experience in TVET, curriculum development, and recently led a team of other consultants to develop a TVET curriculum nutrition program for sports trainers. He is currently at the School of Public Health pursuing his PhD in public health nutrition. Ladies and gentlemen, it is my joy to welcome RD Maxwell Bisala Konla to take us on our today's CPD topic. Before Maxwell comes, RD Aliziaba is co-hosting with me, so you will see both of us working, and as Maxwell even speaks to us. Maxwell, over.
Yeah, all right. Thank you so much. Can you hear me, please?
We can hear you clearly.
All right. Thank you so much for the opportunity this afternoon to lead this discussion. We are all practitioners, so we are going to be doing a little more of a knowledge review and discussion as well. And it's a privilege to lead this discussion this afternoon. And I want to talk to all colleagues on board that we should feel free to get the discussion on, so as we continue with this particular important topic. So without much to talk about, I would like to share my screen briefly so that we can start the presentation. Minute. Yeah. All right, so in the next few minutes, I think we can start. Yes, please, can you see my screen?
Yes, please.
Yes, you can see it.
So it's on a slide presentation mode now. Is this okay?
Very okay.
All right, okay. So the topic we are going to discuss today is nutrition-focused physical finding or nutrition-focused physical examination, a practical approach to anthropometric assessment or anthropometrical assessment. And so by way of outline, we are going to look at what exactly nutrition-focused physical finding or examination is. And then we are going to look at its relevance in clinical practice, and then go ahead to understand the causes and etiologies of malnutrition, because that is what actually warrants a nutrition-focused physical examination assessment. And then we'll demonstrate the skill of assessing a patient's fat and muscle loss using the nutrition-focused physical examination. Then also be able to get a skill of how to identify common nutrition micronutrients using the nutrition-focused physical examination. And this is very important because in certain low research settings where you are not having access to labs, skillful use of the nutrition-focused physical examination can give you an idea of the micronutrient deficiency. And if it's well done, you can be very accurate on what kind of micronutrient deficiency the patient has based on the physical presentation. Yeah, even though in a setting where you have labs, it's expected that when you have the suspicion, you confirm with your labs. But if you are very skillful, you can be very precise on being able to identify a micronutrient using the nutrition-focused physical examination. And then we are also going to be able to demonstrate the ability to assess edema and hydration in patients. So these are the areas that we are going to look at. And then once we are able to go through this, I think that our objective for this particular CPD would be achieved. So what therefore is nutrition-focused physical examination? So this, according to Academy of Nutrition and Dietetics, they actually define nutrition-focused physical examination as an examination of a system-based assessment where each region of the body is assessed, okay? Each region of the body is assessed for physical findings related to nutrition. So it's a system-based assessment of each region of the body to assess for physical findings in relating to nutrition, nutrition indicators. So here, the key important thing here is that it's non-invasive. You don't need to pick up a lab sample. You don't need to take blood. You don't need to, you just have to observe using your hands to be able to do the assessment. And so it's one of the easiest thing to do to be able to know whether a patient is at risk of malnutrition or not. Some patients, before you can even get a lab, it will take you some months. I know that in some settings, if you're in a village somewhere, the sample will have to travel all the way to an urban center. And by the time the labs come back, I mean, if this person is within a period of severe malnutrition, You can even lose the patient before the labs will come back. So this is particularly very important for those who are in a remote setting who may not have easy availability of labs. You can use your physical examination if you are very skillful to start your intervention while waiting for the lab where you can review your diet interventions. So it actually forms part of the nutrition assessment of the nutrition care process. So some people mostly sometimes refer to it as the clinical findings, but in the context of nutrition. So doctors do their clinical findings as well. And even some of their clinical findings has a bit of nutrition in there, but here the focus on nutrition specific. So whilst they will be assessing the body to find out for, they also sometimes look for rashes, which will lead them to a particular disease. We are looking at nutrition related stuffs. Now, one thing I would like to hammer on this is that it appears that as professionals, we sometimes forget to do nutrition-focused physical findings, especially when the patient is healthy and stable. And so this, you can see that when a patient comes, it is easy to do diet history, it is easy to request for labs, it's easy to do anthropometry. But most times, once the patient is not bed-bound or is not at risk of malnutrition, we sometimes overlook it. But I find that to be not the right thing to do. Even when a patient walks in the OPD session and he's healthy and stable, I would still advise that you assess for nutrition-focused physical findings, because as we go on through the presentation, you see that there's malnutrition in the context of chronic disease. When you get chronic disease, you are likely to become malnourished because of certain adjustments of metabolic changes that the body try to adapt. And so I would encourage that let's try and make sure that we add it. I mean, you can do a quick assessment within a very short period. You don't have to be detailed if you don't suspect any risk of malnutrition, but at least check for the palms, check the eyes, you can check the feet, because most people with diabetes may start having edema in the feet. So you may want to know, you look out for ulcers on the body, because once you have a skin sore and you have diabetes, that person needs to be monitored, because that person can be at risk of amputation later if the sugar is not well managed. So all these things are part, and even the signs of abdominal obesity is a nutrition-focused physical findings, because sometimes you can see someone with abdominal obesity, you may think that it is fat, but it could also be ascites, especially for liver patients. So you may want to assess to find out the turgidity of the stomach. So if it's something that is accumulated with fluid, when you gently tap on it, you hear a boom boom sound. It is very much easy to detect. But if it's fat, it's always turgid. So even when you put your hands, you can see that there's a bit of turgidity when there's fat in there. But when it's water, you can feel that it's very easy to palpate, and you see that it's mostly normally bigger than the normal. So let's not always think that because somebody has a pot belly, he may not be at risk of ascites. It's still better go ahead to assess. And so the nutrition-focused physical findings look at evaluation of body systems. So it's basically looks at, any part of the body right from the head to the toe. And then here you are looking out for muscle loss, okay? Whether the person has lost muscles, you are looking out for loss of subcutaneous fats. You are looking out for oral health. And I think as dietitians, we don't do well here. It's as if we've left the oral inspection to the dentist. But as a dietitian, you can also check for that, especially children who are mostly taking sugar-sweetened beverages. Their changes in the teeth can even help you to kind of make an intervention to prevent further damage. You want to look out for hairs, the hair. You want to look out for skin and nails, and then whether there's signs of edema. Okay, sometimes you look for dehydration. So basically, these are the parts of the body or the totality of what you look out for when you are doing nutrition-focused physical examination. Then we move on. Why is it important to do a nutrition-focused physical examination? We all know it's part of the nutrition care process, which helps us to be able to give a comprehensive care. And when you leave one aspect of the nutrition care process out or nutrition assessment out, is going to affect the outcome of sometimes your intervention. And so it is very important. If there's a nutrient deficiency and you are unable to detect, then what it means is that you may not put an intervention to address that problem. And so you may give an intervention that is shortage of what the patient really needs to have. And so as part of our nutrition assessment, we should always try to do a nutrition-focused physical examination. So it's basically done in a hospital settings where you have patients coming in. And I would re-emphasize that no matter the stability or how healthy or not healthy as in how stable the patient is, I would still advise that we should do a nutrition-focused physical examination. You could just do a quick scan whilst the patient is sitting on you. You can watch if there are any symptoms, look at the feet, look at the palms. That will not be detailed as to someone who you suspect is having malnutrition. But I would encourage that let's always do it. It's something that we don't do. And the more you practice, the more you become skillful in that regard. Then it can also be done in community settings. For people who do community outreach, our community nutritionists, our community health nurses, and even nutritionists does this very much often. So when you go into the community, you want to assess for, children who, mostly is the children we do, but it is also, if it's an outreach in a community, you can assess. And so I will encourage that in community settings, you still do the nutrition assessment, especially for the children that you suspect they are high risk. Then outreach programs. So there are people who do health programs. I know people do a lot of health programs now in their churches, in a corporate organization, or wherever you find yourself doing the outreach. It is very important in the schools. So a lot of outreaches are being done in the schools now. And so I remember when I was doing my public health practice, I went together with the community health nurses in the community, and we went to do school health. And at that time, that was my first time going to the community. And when we came, they said, oh, the dietitian is here, come and assess the children in terms of their nutrition-focused physical examination. And so because I had practiced and I had been doing it, it was quite easy to do that assessment. And the report on the oral health was that most of the children had dark-colored teeth, probably from the excess abuse of sugar-sweetened beverages. And then you also had some who had rashes. Typically in Accra, you may not find a lot of malnutrition. There were a few that were moderately wasted. But it's very, very important that you do those assessments so that you know what interventions to put. So when I realized that we didn't leave it there, so we tried to put in interventions, especially for the children who were wasted. We got the parents in there, and then there was a diet plan that was given and in an attempt to address the problem. Unfortunately, I wasn't available to follow up for the outcome because it was just a 3-month attachment. So wherever you find yourself, but this is where the hospital setting is the biggest, most times where you come into contact with most of those assessments. But in a community like where there are wards or maybe there's famine, like currently like in Somalia and those parts, I know the UN agencies, they do a lot of those assessments on the ground. And so if you know how to do it, it's a plus as a nutrition professional. You cannot afford not to know how to do a nutrition examination. Now, we want to look at briefly the indicators of malnutrition before we zoom into the assessment aspect of the key indicators when it comes to nutrition-focused physical examination. So in a joint consensus statement of ASPIN and Academy of Nutrition and Dietetics in 2012,
Hello, Max. We are losing you. I think kindly unmute.
In the middle. So what they are saying is that insufficient energy intake, weight loss, muscle mass or loss of muscle mass, fluid accumulation, decreased functional status, and loss of subcutaneous fat. If you have at least either 2 or more of these indicators, it should be classified as that person should be classified as being malnourished. So for instance, if a patient walks up to you, the questions you should be asking yourself if you are querying the person to be at risk of malnutrition is, one, is there any insufficient energy intake? Is it that the person is not taking much? This you can get it from your diet history when you take the diet history. You want to look for weight loss. Aside asking whether they feel their clothes are loose or they have lost weight within a period of months, you also want to observe for signs of weight loss, which is very obvious. You want to ask, you want to assess for muscle loss, okay? And then you want to do fluid, you want to find out whether there's fluid accumulation as well. So if a patient comes and I realize he has at least 2 of these indicators, then that person will be classified as what? A malnourished patient. Now, once you identify the person, it doesn't end there. You need to put in an intervention to be able to solve the problem. The aim of every assessment is to put in an intervention. So it is very important that when you make that assessment, you go on to put an intervention and try to monitor for outcome. So basically, if someone has weight loss and loss of muscle mass, that person is a malnourished person. If it's fluid accumulation together with decreased functional status, at least 2 or more, then you are classified as being malnourished. And we want to look at how big is the problem of malnutrition? How big is the problem of malnutrition? So it is estimated that about 60% of patients are malnourished even before they get admitted. Okay. Now, a major contributor to increased risks of morbidity and mortality is malnutrition. And so as nutrition professionals, we need to always put in interventions to make sure that our facility level, we get the needed attention when it comes to nutrition issues. A lot of patients have died just because of nutrition. But sometimes our other clinicians do not pay so much attention when it comes to nutrition. And this is not just we saying it, this is backed by evidence. I mean, when I was reviewing literature, I saw a lot of articles that contributed to morbidity and mortality in chronic disease patients. So they actually died because of the malnutrition, making the condition worse, and not necessarily because of the condition. And so it is important that we always make, measures that they refer patients to us. I remember when we started our clinic at Legon, we were not getting enough referrals. And so what we did was to develop a malnutrition tool. We used the MAST tool to develop it. It was just a 1-page document, and the nurses were to administer. And there was a score. So if a patient takes 1 or 2 of those indicators, the person was classified as a malnourished person and was referred. And when we implemented the tool, we realized that a lot of referrals came in because we're getting referrals by using the tool. And it was really, really helpful. It got to a point we realized that the awareness has gone up, and so there was no need to use the tool. So if you are starting a clinic in a hospital somewhere and you are not getting the referrals, you may want to develop a malnutrition tool based on certain indicators, then you'll be able to get your referrals coming in. So at the point of entry, the nurses will do the assessment, and you can even get your national service personnel to do the assessment if it's a normal OPD level where you are all at the same place. And that will help you to get a lot of patients. Then it is also estimated that 1/3 of hospitalized patients are malnourished. Now, this is very evident even in our hospitals. I had a patient who we are currently managing who has starved himself for 30 days because of dry fasting. So the church was doing 40 days fasting, and he decided to join the fasting. But intermittently, once the church was doing the break of fast, she decided to take it a step further. So she will do 3 days dry fasting, join the church to do the normal intermittent fasting and break at 6. Then after 3 days, she will do dry fasting again, only water. And this patient came in at a point where she could not walk anymore. And so when she came, her HB was 12.7. Just on admission, after a week, the HB dropped to 7. So this patient came in, the HB was not bad, even though it was slightly low, it wasn't bad, but after just a week, she has gone into malnutrition. And so we had to come in to intervene. So it tells you that as soon as you are admitted, you are already at risk. And know that any patient who is on admission for more than a week or even 3 days is likely to become malnourished. And then malnutrition is associated with increased risks of length of stay in the hospital. So the more you are malnourished, the more you stay longer. And then we know that nutrition interventions are more like cost effective. And so if we put in a nutrition intervention, we'll spend less, but we'll get maximum outcome in terms of patient care. So we want to look at the etiology of malnutrition. So when you identify someone who is at nutritional risk, mostly there's either a compromised intake or loss of body mass. Okay, so once you go into a state of starvation, you begin to deplete your glucose store, you go into your glycogen in the muscles and liver. When that is depleted, the body resorts to the use of fat, and there you will have keto bodies production. Once the fat is depleted, the body now begins to burn or break down your muscle for you to be able to use to survive. And that is where you begin to see the noticeable changes, okay? So inflammation is an indicator, and this inflammation happens because the body begins to adjust because of the stress of malnutrition. And so there's metabolic adjustment in the body, and that leads to inflammation. One of the chemicals that are released in the blood during this period, or the inflammatory cytokines, one of them is the C-reactive protein. And so in certain jurisdictions, they use the C-reactive protein as a measure for malnutrition. So if there's inflammation, you want to ask whether this patient has inflammation or not. Now, if there's no inflammation and the person is still malnourished and you can see visible signs of, wasting, then that person is probably having starvation, like my patient that I'm talking about, who went onto the 30 days dry fasting intermittently every 3 days in seek for spiritual power, and that is very important, because with those ones, you would not see you actually not see you will not see the edema when it's severe starvation. So for instance, when you look for, when you are trying to assess children who are in famine designated area as a result of war, whether it's Somalia, whether it's Ukraine, those children may typically not present with edema. They may not have edema, but you can see visible wasting. So when the malnutrition is as a result of severe starvation, then it is mostly without edema, okay? Then if there's edema, you want to ask yourself whether this edema is mild to moderate or it is severe, okay? Now, when it's chronic disease related, like let's say kidney disease, when a person has let's say pancreatitis, when the person has cancer, when the person has rheumatoid arthritis, or any other chronic disease that will last long, mostly you would have very mild to moderate malnutrition. But if it is in acute disease, let's say it's an infection or burns, mostly you would have the inflammation very severe. This is because it is very short while, so the body tries to respond, and inflammation is one of the things that happen. So you want to ask yourself where this malnutrition is emanating from, whether it is from starvation, chronic disease, or is from acute disease injury. And so basically in acute illness, you have severe inflammation. In chronic illness, you have mild to moderate inflammation. And then in social environmental circumstances, just like in a war-torn zone where people are not getting food to eat, or the person intentionally starve him or herself, you may have chronic starvation. In those instances, you may not see any inflammation. So inflammation alone is not enough to say whether the person is malnourished or not. You may need to look for other signs. Now, we probably will want to move on to some of the conditions in acute illness that can cause inflammation. You can have infections, you can have burns, closed head surgery, injury, you can have major surgery. All these things can result in severe inflammation. And when you come to the chronic illness, organ failure, kidney, liver, you may have a mild to moderate inflammation. Then when it's chronic, you may not have any inflammation at all. Then based on these indicators, they actually, Academy of Nutrition and Dietetics are actually helping us to know whether the malnutrition is severe or not, based on the context of whether it's acute illness, chronic disease, or it's as a result of famine or starvation, based on environmental or exposures. So when you have weight loss, that is basically when you have weight loss, that is more than 2% of your weight in 1 week, and you have weight loss more than 5% in a month or more than 7.5% in 3 months, we actually, and you have an acute illness such as Benz, we would say that you have a severe malnutrition. So if the weight loss is in the context of chronic disease, it's 5% and greater than 7.5, so the differences are not much. If it's in the context of starvation, then we are looking at weight loss of greater than 5% of your weight, and then 7.5% of your weight in 3 months, and then the others follow. Then when you come to intake, when you have intake less than 50% of energy intake compared to your estimated energy needs, for more than 5 days, then we actually say that you have severe malnutrition when it's in the context of acute illness. In chronic disease, we are looking at 75%. In the context of starvation or war or famine, where you are not getting enough food, then it's 50%. So there are differences. And then once we share this slide, we can look at this later so that we don't spend a lot of time here. Now, what then? So once there's malnutrition, once you can identify malnutrition, then the next thing to do is to assess your nutrition-focused physical findings to find out what is the extent of that malnutrition on the patient. So in this situation, you want to assess for fat and muscle loss. You want to assess for micronutrient deficiencies. You want to assess for edema, and then as well as what? Dehydration. So these are the key things that you look out for when you are doing the assessment. And one thing I would like to let you know is that the assessment should be very systematic. Mostly, I prefer to always start from the head down to the feet. There are others who will start from the feet right to the head. But at every point, when you are going systematically, you don't miss certain important assessments. Instead of just assessing here, then you go and assess the leg. Before you realize you've forgotten that you've not assessed the chest area, you have to come back. But when you start from the head coming down, and you are looking from the hair to the bone, the cheekbone area, then you come to the eyes, it's very easy not to forget anything, and it helps you to capture most of the important things. And so because of time for practice, we mostly sometimes end up skipping assessment of nutrition-focused physical examination, especially when we think the person is stable and is not at risk. But it is important that we do that. If you know how to do it, you should be able to find practical ways to limit the time that you use for that assessment. All right, so we are going to begin to look at the assessment. And like I said, we are going to do it systematically. We start from the head. So the head and facial region. So I would show you some of the things we have to look out for when you are looking at assessment for those regions. So in this situation, you are going to assess for fat, muscle loss, and micronutrient deficiencies, as well as edema and then hydration or dehydrational status of the patient, whether the person is dehydrated or well hydrated. So always have in mind you're assessing fat loss, muscle loss, micronutrients. This is what we need to even be more interested in. And so it will tell you a lot of stories about the nutritional status. In stable patients who are not at risk, you may not find anything. It's fine not to find anything, but I would want you to have the consciousness to assess. And then we know that you did the assessment, but you didn't find anything. It's better than just keep and think that, oh, this person may not have anything like that. What if he's there? And we have seen this in most of our students' exams. When you give them a patient, especially their final exams, all they do is they do anthropometry, they do their diet history. You see that they are able to assess the labs. Sometimes they do a bit of social history. Nutrition-focused physical findings, there is nothing done. And I think it's because of what they see as practice, because typically we usually don't do that unless the person is malnourished. But it's important that they assess it so that we know that you have the skill to do that. if you assess and you tell me you don't find anything, yes, it is possible not to find anything. But to just assume that this person may look okay, so there's no need to check for that. No, because some stable patients have anemia, which you may see in terms of paleness in their arms and hands and eyes and all that. So here in this region, we are looking at hair. We are going to assess the hair. We'll look at how to assess the eyes, how to assess the mouth, the gums, the tongue, the orbital area, and then the facial muscle. And this facial muscle is very, very easy to see. When someone is losing weight, people are very close to the person, even when it's not severe, are able to know that something has happened. So you want to assess all those things because you see a lot of changes in these areas within the head and the facial region when the person is malnourished. Now, the first one I want us to look at, as I said, we'll go systematically, we'll look at the hair. So what do you look out for when you are assessing the hair? Now, this can be very, very difficult in aged patients because when you are aged, you tend to lose hair. There are also people who are bald. So be careful not to classify a bald person as having alopecia because obviously if you are bald, you may not have hair there. It doesn't mean you are malnourished. And so you would have to find a way. There is this thing about baldness that when you see, you know that this is not alopecia, this is baldness. And for a female who has done her hair, you may not find anything. So the hair findings are typically more important in children, especially children who are under 5, because you can visibly see the changes in the color of the hair. But you can look out for patchy hair loss. So if the person has not done her hair, if it's a female and it's just the normal hair, you can look out for whether there's hair loss, whether the hair is can easily be plucked. You can look for color changes. This will work for the children. So most of the children who are malnourished, you will see a brownish hair, which could be an indicator of protein and other micronutrients. So when it comes to hair, when the person has hair loss, and then you can confirm whether this person has baldness or something, because once you ask and you say no, he doesn't think it's baldness, and then you see that this person has hair loss, like you can see in this picture, this is not a typical presentation of baldness. Okay, this is absolutely hair loss. This particular picture looks a bit of baldness, like it's baldness, but you can see that it is not just one place. In other regions of the hair, you can see that the hair is also not available. So you can probe further. So mostly the hair changes in adult or aged patient, you have to make sure that you get your differentials so that you don't end up thinking the person has alopecia. And alopecia is just someone who has a hair loss. The hair is mostly easily plucked, and then you see color changes in that, especially when it's in children. So that particular deficiency is a deficiency of protein, it's a deficiency of zinc, it's a deficiency of what? Biotin or iron. So when you observe that a patient has these things, then you should know that this person is likely to be at risk of protein deficiency, zinc, biotin, and then iron. Now, what it means is that when you are putting your intervention, you must make sure that you cover for all these nutrients. This is very important. And that is the reason why we do the assessment. So imagine if you have a patient who is at risk of these deficiencies and you couldn't pick it up. You are going to do an intervention that probably you may not consider these nutrients. And that is not going to help the patient. He may come with diabetes, but once you see that these other signs and symptoms are there, you may want to modify your intervention to cover for the other nutrients as well. Then moving away from the hair, we move to the next part of the body. So here we want to look at the temporalis muscle. So the temporalis muscle is basically between your eyes and your cheekbone. So there's a muscle here. So you can see the arrow here. So all this, this brownish color is the temporalis muscle. Now, there's something about it. When someone is severely malnourished or is losing weight, you have a dent within both sides, either the right or the left. So with the patient standing in front of you, you use your index finger and then place it at the point where the compressions are. So you see a deep compressions somewhere here and here as well. So you gently put your index finger there to palpate the muscle around that area to find out whether there's compressions or there's hollow compressions. Once you put your hand in there, when there's fat, you can feel a bit of some muscle or fat in there. But when there's muscle or fat loss, you will see that it is hollow. You can feel the hollowness of it. Sometimes it may be mild, sometimes it may be severe. So if this patient is before, you can put your index finger and then you palpate those areas of the temporalis muscle to find out whether you get a hollow compressions. Now, if there are hollow compressions, sometimes you may not need to touch, but you can see the hollow dents in some of these patients. When it's very severe, you can see it. When it's moderate, you may not pick it up unless you do the palpation. And so once you see that that place is a bit deep, then you know that there is some form of muscle loss or fat loss within that area. That is why there's a hollow compression in that part of the body. So it is basically by the picture you assess is based on here and then here. So both the left and the right. And so you gently put your index finger there and do the palpation. And so this would show you whether the person is losing fat or muscle. Then we move on to another assessment. So after assessing that, you want to look out for sunken eyes. You want to look out for sunken eyes. So in terms of the eyes, you can visibly see that the person's eyes are sunken. You can see a hollow nature of the eyes, as if the eyes are popping backwards. Okay, so this time you may not see the eyes coming out, it falls inside. So once you see, based on the picture here, once you see those sunken eyes, it's an indication of severe protein energy malnutrition. So which could be a deficiency of protein intake, fat and carbohydrates. But basically the two nutrients that are likely to be at risk here is both protein and then carbohydrates. And I believe that it is easy for all of us to see when someone has a sunken eyes. It is typically very easy. So you see that the hollow nature within the orbital region, and you see that the eyes are falling backwards. And that one, you may not even need to touch the patient. You just observe by looking at the patient. And once you get that, it is not a deficiency of, it could be a deficiency of other micronutrients, but the main nutrient here is either carbohydrates, protein, and fat, specifically protein energy malnutrition. And so that is the other thing you assess. So you see that right from the hair, you go to the temporalis muscles to look for the hollow compressions within the temporalis area. Then you come to the eyes. So when it's systematical, you don't forget. Then if you are started from the feet, then you come to the eyes, you go back to the hands. Before you realize you would have forgotten to check for a lot of things. So we are still moving. So right from the eyes, where do you move next? So, sorry, my slides are not moving. I don't know why. So let me quickly see if I can sort that out. Okay, so here we go. All right. So in terms of the eyes, we are still on the eyes. So you look at sunken eyes. You also want to check for paleness in the eyes. So for paleness in the eyes, you want to find out whether the person is at risk of iron, B12, and folates. The good thing about that, these three micronutrients are related because you need B12 and folate to allow for synthesis of iron. And so if someone is having anemia, he's most likely going to be deficient in either B12 or folic. Sometimes the anemia can be related to other chronic disease, but paleness in the eyes can be a deficiency of these three nutrients that all have a lot to do with iron metabolism. Then you look for night blindness, okay? So with the night blindness, you would see that the person, you would have to ask questions to be able to know that. You cannot know whether the person has night blindness by just looking at the eyes. But when you have any suspicion that you think that the eyes, there are suspicions in the eyes, then you can probe, or you can even ask whether the person has challenges seeing in the night. So you only get that information by asking the patient. So what you do with the assessment of the eyes is that with your index and your thumb, what you do, you gently, like how mostly we assess at our clinic, you gently press the eyes so that you can see the eyeball and the eye area very well. So mostly when you look around the cornea region, when you see that the person has a very pale eyes, then it's an indication of what? The iron B12 of folic acid. But mind you, some patients naturally have very white eyes. And so the fact that somebody probably has very white eyes does not mean the person is anemic. The difference between the paleness in the eyes is slightly a bit different from when the person has white eyes, because the presentation may look a bit different. So you have to be careful to ensure that you do not think the person is anemic when he's not. Now, mind you, as you do this assessment, you are waiting for your lab to confirm your suspicion. So nutrition-focused physical finding is, even though objective, but it depends on the skill of the person. So somebody can assess and think that this person has pale eyes, another person comes and sees that there's nothing inside. So the final judgment depends on the labs. So once the lab comes, then you confirm your suspicion, because a lot of things can really show that the person is malnourished. Meanwhile, he's not, especially those who have very white eyes. So you want to be careful you don't classify that as paleness. So just remember that in paleness, we are looking for iron, B12, and folic acid. The deep compressions in the temporalis muscle is as a result of muscle and fat loss. Then the hair changes, we are looking at protein deficiency, we are looking at zinc, we are looking at B12 and other micronutrients as well. Then we move on to the orbital area. So the orbital region is the region around the eye. So this whole area is the orbital region. So how do we assess that? It's also an assessment for fat and muscle loss. It's an assessment for fat and muscle loss. And so what you do is that you stand directly in front of the patient. Okay, you stand in front of the patient and touch above their cheekbone. So hollow loop depressions, dark circles, or loose skin within the orbital area is an indication of severe malnutrition. If it's slightly dark, it's mild to moderate. Then if you are well nourished, we expect to see a slightly bulge fat, because there are fat parts there that you can easily feel by putting your hand there. Once you put your hand there, you can feel the bone there, then it means that there is some form of fat breakdown or muscle as well. And so let's look at how the presentation will look like in terms of picture. So this is a normal person with a normal orbital region. So you see that it is very easy to see. Now, when you come here, when it's mild, you begin to see some dark patches around the area of the eye. And then you see that there's a bit of compressions, but it's mild. Then if it's severe, sometimes you don't even need to put your hand there. When it's severe, you can easily see. So you see that there's deep compressions or hollow look. So you see that as the eyes are falling back, around the area, you can see that there's a lot of hollow compressions around the orbital region. So the orbital region is the region that houses your eyes. So once you assess that and there are hollow compressions, as is seen in this picture, then you can say the person is severely malnourished. If it's mild to moderate, you see a bit of dark patches around the eye. And then if it's a normal person, as you can see, you will not see any of these symptoms in there. Sometimes some people may have eye problems, so you may have some redness around the eye. It is not enough to think they are malnourished. You want to find out whether they have eye issue or something, because if you have a watery eye, it can really cause a bit of somewhat dark circles around the eye area, but it doesn't mean you are malnourished like this. Okay, but sometimes it's mostly accompanied with the sunken eyes as well. So this is very easy to be able to identify. Then we move on to the mouth. So we have moved from the eye. Now we are coming to the mouth. So like I said, so we started from the hair. Around the mouth area, there are certain indicators you look out for. So you look out for swollen, cracked lesions around the corners of the mouth. And so that is what we call the stomatitis. So when you have cracked lips around your mouth, we refer to as stomatitis. And there are two of the presentation. You can also have what we call chelosis. Chelosis is mostly patches at or sores at the corners of your mouth. So you have one here, and then you have another one here. So the first picture as seen here is chelosis, and then this second one is stomatitis. So when you have patches at the corners of the mouth, it's chelosis. When you have cracked lips around your lips, with marked inflammation, it is stomatitis. Now, what is the possible deficiency of this presentation? Now, most times it's a deficiency of riboflavin, vitamin B6. Yes, vitamin B6. You have niacin, biotin, or folic acid. So these deficiencies actually cause these symptoms. Sometimes you may not have both symptoms if you have at least 3 of these deficiencies in some of these micronutrients or vitamins. You can still present with these symptoms. But it just tells you what your intervention should be targeted at, especially when you have this. You are typically not going to see this in a stable patient. It's mostly common among people who are chronically ill for a very long time and they are not getting the needed micronutrients, or they are probably children who are malnourished. You get to see that, especially for people who are managing children in areas where there's high risk of malnutrition. Then we look at the tongue. So right from the mouth, we are going to the tongue. So in terms of the tongue, the symptoms or signs you are looking out for is glossitis. Glossitis is red, swollen tongue. So you see that the tongue is swollen, and then you see a bit of redness in the tongue. And so you can assess this by asking the patient to open the mouth and bring out the tongue. And so sometimes you may even want to use a light. You want to use a torch light or whatever light you have, your phone light, or even the equipment that we use. We have these medical equipment that we use to assess, if you want to assess the oral hygiene, and it comes with this equipment that comes with light. So once the person opens his mouth and brings out the tongue, you put the light source on to find out whether the tongue has a normal presentation or is actually swollen or red. Once you see swollen tongue and there's redness, you want to query vitamin B12, you want to query riboflavin, niacin, B6, biotin, and iron. So any of these micronutrients at least can cause this particular presentation. In terms of iron and B12 and folic acid again, or folate, you have pale tongue, because when there's adequate amount of blood, there's supposed to be adequate circulation around the tongue area. So the tissues of the tongue are well circulated. You see a reddish tongue, but this reddish tongue does not necessarily mean that it is a malnutrition as a result of the glossitis, but it's mostly accompanied with inflammation. So if you don't see inflammation and you see that the tongue is white, you can query iron deficiency. But you see, a lot of things can mask your diagnosis. So it's important to confirm with your lab. It's very important to confirm with your lab. Then you want to watch out for oral thrush. Now, this is not typically a macronutrient deficiency, but you want to watch out for issues of lowered immunity, whether the person is at risk of retroviral infection, because that has an impact on your management. And so you can refer to the doctor to be able to put in the right interventions to salvage the situation, because if the person has HIV and is not picked, it's going to affect your nutrition outcome. And so moving away from the tongue, we move to the teeth. So what do you look out in the teeth? You look out for deficiencies of calcium, vitamin K, vitamin C, and magnesium. So when you have swollen, sore, and bleeding gums, of course, once it's bleeding, it could be a deficiency of vitamin K, because we all know the role of vitamin K. What vitamin K does is to stop or prevent bleeding. So when you are bleeding, you may want to make sure that the bleeding doesn't take long. If it takes longer than is expected, then something is wrong. It could be a sign of vitamin K deficiency. And we know the role of calcium in development of strong bones and teeth. So if you are having a bleeding gums, it could be a possible calcium deficiency. Vitamin C comes in here again, and then magnesium as well. Now, like I said, and I always say that these things are not a straightforward thing. As soon as you see these things, you don't go ahead and diagnose the person as having vitamin K or calcium deficiency. You want to confirm with your labs. So the labs would give you a clearer picture of what your suspicion is. And so once you do this, then you confirm with your lab. So you make the person open the mouth, and then the person will show you his or her teeth, and then you watch out for whether there's bleeding in the teeth or not. There are people who bleed without even knowing. And when that happens, it is important to be able to take it further, to do some lab analysis to find out whether indeed your suspicions are right. Then you continue with your treatment. But even if the lab is not available, you can still do your intervention with these nutrients in mind, because at the end of the day, you may still need them for other important body function. And so if you put an intervention, you have nothing to lose. And so you go ahead and make sure that your sources of calcium, vitamin K, and vitamin C is included in your diet intervention for such a patient. All right. Then we move on to the neck area. Okay. So in the neck area, we look out for whether the person has an enlarged area in the neck. Okay. So that enlargement could be a symptoms of goiter. So, and we know goiter, the symptoms is iodine deficiency. And these days, a lot of people out there are consuming the rock salts, and they are trying to say all sort of things with regards to the iodated salt. So I had people coming to tell me that they have heard that the rock salt is healthy. So what do I have to say about that? And we all know what iodated salt has helped reduce the incidence of goiter, because those days in the northern part of Ghana, the statistics were very, very high. A lot of people were having goiter as a result of iodine deficiency. Since the introduction of such an intervention, we've seen a drop in the iodine, but once in a while, you still have some patients even having goiter without knowing, especially those who have a very bigger neck. So they think it's fat, but it is actually a growth of goiter, which is probably ongoing and they are not aware. So you gently put your hand around the area and palpate the neck to find out whether you don't feel any signs of a lump inside the skin, below the skin. And so once you do that, you may want to refer to the medics. Once you are not sure it's iodine, it could also be a tumor. So you want to refer to confirm whether it's indeed goiter or it is iodine deficiency. But yet still, as you are doing your intervention, you want to consider adequate amount of iodine, so that while the investigation is ongoing, if this person is actually having deficiency in iodine, you can address the problem. Then we are going to now look at the chest area. So in the chest area, you look at or the thoracic or abdominal region, you look at the chest area, you look at the ribs, you look at the clavicle, you look at the scapula. So watch out for visible ribs. This is very common to see in very severely malnourished patients, and especially our stroke patients. When they are on NG tube for a very long time, you could visibly see a lot of, visible ribs. That patient of mine who underwent 40 days fasting for spiritual power actually had very visible ribs, and you could see that, the ribs were very easy to see. You can even count the ribs as seen in this picture. So mostly you may not even want to touch the patient. You can visibly see the ribs. Okay, so if the patient has a clot on, you can ask them to remove the clot so that you look at it, but make sure that you ensure the confidentiality and the privacy of the patients as much as possible. So the visible ribs is a sign of fat and muscle loss, protein energy malnutrition, and so in very severely wasted patient, you can easily see it. Then you can see the clavicle. So the clavicle, which is around the collarbone, so you can easily see the bone there. If you want, you can put your hand gently there to palpate the bone, and then you can feel that there is no muscle or fat on it. Then for the scapula, what you do is that with the patient sitting upwards, you with your hands wrapped in a hand glove, you put your hand at the back of the scapula to feel whether the bone is prominent or there's muscle or fat covering it. So when there's no muscle or fat, you can feel the prominence of the bone at the back. You know, so sometimes you can let the person bend the arm by the side, and when it happens that way, or they bend backwards a bit. So as the person is sitting, he'll bend the head a bit so that you find out whether there's prominence of the scapula at the back. But sometimes even when it's severe, by sitting, when you put your hand there, you can feel the prominence of the scapula, and that is also a deficiency of protein energy malnutrition, which would be a deficiency of carbohydrate, fat, and then carbohydrate, fat, and protein as well. And so it mostly happens from severe starvation. And you come to the arms, which is your arms together with your hands all the way to your fingers. So there you look out for hand grip, you look out for paleness in the palms, you look out for edema. So let's quickly look at that. So we don't have this equipment. It's called the hand dynamometer. So it's used to assess hand grip. So once the person holds the equipment and tries to press it, then you want to see how grip or how strong is the grip strength as the person presses the equipment. So a reduced grip strength is defined as 2 standard deviation. So there are calibrations on the equipment. So when you try to press and you have less than 2 standard deviations, then if it's below 2 standard deviations, then we say that there is a reduced hand grip. And then reduced hand grip is often sometimes one of the first things that decline with malnutrition, and is usually detected before fat and muscle wasting is present. So it is a sign of weakness, because as you are not eating and you are malnourished, you tend to deplete your glucose and glycogen stores. And so you become weak. And once you are weak, it will reflect in your hand grip as well. So that could also be an indicator for malnutrition in terms of carbohydrate and fat. Then we are now going to look at we'll look at the skin. So in terms of the skin, you look out for what we call the pellagra. Pellagra is a deficiency of niacin. So you want to find out, once you see a presentation like this, I mean, it should tell you that this person is likely to be at risk of a micronutrient. Specifically, we are talking about niacin here. So you want to look at food sources that are high in niacin to be able to address this problem. Still on the hand, you want to look at the biceps and the triceps. Okay, so that is also an indication of muscle and fat loss. So when you get the person to stand with the hand up, you try to hold the muscle and see whether you can pull the muscle away from the arm. And so once there's wasting, you see that the skin can literally be pulled away, and it takes a long time for the skin to get back to normal. Sometimes as they raise their hands, you can let them shake their arms. When there's fat loss, you can see that the muscle there will be shaking because you have lost some fat in there. So the muscle will be there, but you feel that there's a flappy muscle. And this is very common among patients who are obese and have lost weight. And so after losing weight, they'll come back and say, can you help me to be able to strengthen my arms? Mostly a little bit of protein intake can help build some muscles there, but mostly those things will have to be corrected when they do a bit of exercise targeting those areas to strengthen the muscle. And when it's severe, you can see easily because the bone will show within that. You cannot feel the muscle. You visibly see the bones around that arm there. And so that is what you look out for when you are assessing for the triceps. Then for the hands, we are looking out for edema. Now, when you find out there's edema, you want to find out what kind of edema is it. So you gently press your hand, your index finger on the hand to see whether you get a hollow compression. So whether it's pitting or non-pitting. So once you put your hand there and it's pitting, mostly pitting edema is mostly associated with protein deficiency. So when there's a deep hole on the surface of the hand after you press and then it takes a long time to recur, then you can say this person is likely having protein deficiency or what we define as hypoproteinemic edema. And this happens because once you have less protein, you tend to have less amount of vascular oncotic pressure. And once there's less protein in the blood, the water or the fluid in the blood will move out into the interstitial spaces, and it's mostly the hand and the extremities around the feet that tends to suffer most. So when you're watching out for edema, you watch out for those parts of the body. And so you want to increase your protein intake. And once there's adequate protein, you are going to increase your vascular oncotic pressure. And that kind of help to maintain the fluid balance and prevents further water from coming out around the extremities. And so when it's pitting, it could be a result of protein deficiency. Now, there are times the edema may not be pitting, especially whether it's in the feet or in the hands. Then you want to ask yourself why it's not pitting. So when it's not pitting, you may want to query and find out whether there could be other conditions like renal failure or heart failure that is causing the water to come out from the blood into the interstitial spaces. Because once there's a heart failure, you have regurgitation of the blood towards the right ventricular area through the right atrium. The blood will not clear. And so once the blood is stagnant, the water in the blood is likely going to come out into the interstitial space, and mostly it comes around the arms and then the feet as well. Sometimes you have a puffy face. So all that you want to rule out whether it is not related to the condition or it is as a result of malnutrition. Malnutrition will always give you a pitting. If it's not pitting, it could be a sign of other causes, maybe from the disease and not necessarily as a result of malnutrition. So you rule out by looking at whether it's pitting or not pitting. Right, then you want to look at paleness in the hands. And so as you can see in this picture, once your hands are pale, it is visible to see. Now, once you have adequate amount of iron or you are not anemic, you have proper, vascular, how do you call it? There's a lot of blood flowing around the hands. So you see that there's proper circulation around the hand area because there's adequate blood. So you see this reddish patch in the arms. They are all as a result of red blood cells underneath the skin around the palm area. Now, this is another arm that is pale. It means that there's anemia here. And so as you can see, so when you look at this hands, is mostly very, very white and looks very pale. So as your suspicion, then you go for your lab to confirm whether this person has anemia. And once the person is anemic, then you put in your intervention. The nutrient deficiencies you watch out for is iron, B12, and folic acid as well as or folates as well. So these three could cause the paleness in the arms. But mostly they will present it when they have anemia. But we know that the B12 and the folic allows for proper synthesis of iron. So for me, if you are treating a patient who is anemic, you would also want to look for your sources of B12 or folate, because we may not have a proper lab to be able to tell us what the cause of the anemia is. And so you may want to just address them holistically, because even the B12 and the folate, you may still need it for other important vital functioning as well. Then we look out for what we call the dorsal hand. Over there, you are looking at the interosseous muscle, the interosseous muscle. So here you make the person form a circle compression between the index finger and the thumb. And then you watch out for the thumb area and that of the index finger, whether there's a hollow compression here. So as you can see in the picture. So if you see a hollow compression, then it could be a sign of wasting as a result of either lack of adequate intake of protein, carbohydrates, or fat. However, you must be careful because some patients maybe have disability, they may have had injury. So you must be sure that this person has not had any injury around this area, because an injury can also cause a presentation like this, which may not necessarily be as a result of malnutrition. But of course, you may want to look out for the other indicators and your lab to be able to confirm your diagnosis. And so as you see here, so as you can see in this picture as well, so you see there's a hollow compression here as well. So this could be a sign of malnutrition, basically specifically more protein, carbohydrate, and energy, or protein energy malnutrition. And we look out for edema. Okay, so from the chest area, we come to around the feet. You want to search for edema. So as I was saying, edema is a supportive diagnosis. You cannot use only edema to say that somebody is malnourished. It just helps you to be able to confirm your diagnosis. So mostly it is rarely used, but it is very important because it will help you to be able to know whether this patient indeed, whether there's pitting or no pitting, and that can help you to identify whether it's of nutrition origin or not. So sometimes you can forcibly have weight maxing or the weight loss, okay? So as the person stands, you just put your hand and then you press and find out whether there's hollow compressions in the feet area. So mostly when there's edema in the feet, it could be as a result of maybe a chronic disease, it could be heart failure, it could be liver disease, it could be kidney disease. So you want to be sure whether it's of nutrition origin. So once there's pitting and you see there's peeling of the skin. So when you see this patient, there's peeling of the skin. So when you have this peeling of the skin, it could be a sign of micronutrient deficiencies, mostly the B vitamins. It could be a sign of protein deficiency as well. And then once you have pitting, then that also even further confirms your suspicion for probably protein deficiency. And so once your lab comes, you would want to watch out what is the situation in terms of your albumin. However, in current research, albumin is not a good indicator for malnutrition now, because a lot of researchers are showing that some people may have low albumin, but they are not malnourished, because it could be an indicator of response to other chronic disease. And so you may want to look out for other, micronutrients or other assessment to confirm whether indeed this person is malnourished or not. Then in terms of the edema, when it's 2 millimeters depression, when you press and it's just 2 millimeters depression or +1, it means that that is more of, mild. So when it goes 4 millimeters deep, a few seconds before it takes to rebound, then you are going towards between moderately to mild. Then +3 when it's 6 millimeters, it means that that is quite moderate. And then when it's +4, it is severe. So the nature of the compression would tell you whether it is moderate, whether it is mild, or whether it's between mild and moderate. When it's +3, when it's moderate is +3, and +3. When it's +4, then it's severe. So once you press, mostly this works on the feet. It works on the feet and also around the leg area where there are possibly a lot of fat stores or muscles where you can easily assess that. So once you press, you watch, and then you need to ask yourself whether the edema is pitting or not pitting. So whether it's pitting or not pitting would help you to know whether it's probably of chronic disease origin or probably is associated with protein deficiency. So mostly if it's protein deficiency, as in a case of hypoproteinemic edema leading to low vascular oncotic pressure, you would definitely find pitting in there, and the pitting is very visible. But if it's chronic disease like heart failure, you may find out that there's no pitting. And so once it's not pitting, you know that there's a condition that can actually cause that, then it's probably not of nutrition origin. Then you want to assess for dehydration in the hands. Okay, so in assessing for dehydration, you ask the patient about her urine output, whether the person has had urine for the past 2 to 3 days. If the person says that he has not had urine for a whole day or more than a day or more, it means that that person is likely dehydrated. You want to ask whether there's an urge to drink. When there's no urge to drink water, it could also confirm your suspicion. Then you do what we call the skin Tego test. So the skin Tego test, you gently use your index and your thumb finger to pull the skin away from the hand as seen in this picture. So when you pull, how long it takes for the muscle or the pull to recoil back will tell you whether the person is hydrated well or not. So if it takes a longer time, it could be classified as either moderate or severe dehydration. When the skin falls back quickly after pulling it away, then it's possibly normal and the person is not dehydrated. So this can be done around the hand area. And so sometimes also some people do it around their arm area to find out how easy it is to pull the skin away. So when the person is lost weight or dehydrated, you can easily pull the skin away, the muscles away from the skin as seen in this picture. And so that is how we assess for dehydration. And so that's probably brings us to the end of the presentation. So my conclusion is that the accurate use of nutrition-focused physical examination can provide a very objective measure to determine the nutritional status of patients, especially for those of us who are in low settings areas where getting labs or access to labs, or it takes a long time before the lab results will come. You can use the micronutrient assessment from the nutrition-focused physical examination to put in your intervention whilst waiting for the lab. Mind you, you have nothing to lose. There's a bit of less risk because this is diet. So even if your the lab comes and is otherwise, at least by educating the person on healthy eating from the sources of the micronutrients, you have nothing to lose. The person will still be able to use some of those micronutrients for other important body function. But if you want to wait and the lab will take a long time, then what it means is that by the lab will come, your patient would have been severely malnourished. So in summary, nutrition-focused physical examination is very important, and I would want us to ensure that we try to add it as part of our practice wherever we find ourselves in the hospital setting, especially when you are taking care of patients who are having chronic disease. It's basically done systematically. You can start from the hair, then you go to your eyes, you go to the temporalis muscles. You can look for sunken eyes. You go all the way to the cheekbone, whether there's prominence of the cheekbone. You look at the mouth area to look out for chelosis or stomatitis, as we discussed. You look at the tongue, look for glossitis, look at the teeth to find out whether there's bleeding gums. Then you come to the chest area, you are looking out for visible ribs, you are looking out for presence of a visible scapula or collarbone, and that is an indication of malnutrition. You palpate your scapula to find out whether you can feel the presence of the bone back there. Then you come to your abdominal area, assess for whether it's abdominal fat or it's ascites, and the turgidity of the abdominal area will tell whether it is fat or muscle. And then you want to look at the skin. You want to look for signs of pellagra to find out whether it's niacin deficiency the peeling of the skin is an indication of micronutrients and protein as well. Then you want to go to your feet to check for signs of edema. In the palms, you look out for your anemia, the paleness of the palm as well. And then I think that once you do all these things, it helps you to have a greater perspective of what is happening. And so when the labs come, based on your suspicions, you can even request for further labs. And I think once you get this information, it will be able to help you to put up a very good intervention. So nutrition-focused physical examination is very important. And I want to encourage us all to ensure that we add it in our assessments and not just always forget about it because we think the person may be stable and may not have it. You can go ahead to assess. If there's nothing inside, that's fine. But the assumption that this person is stable just works to me. He's sitting in an OPD, he may not need to be assessed, is wrong. Because once you see certain things, it could help you to model your intervention and make it better. So I would like to bring the presentation to an end here. And thank you so much for your attention. So this brings us to the end of our presentation this evening. So I would like to end here and hand it over to Anthropometrical. Thank you so much. So Anthropometrical, over to you.
Hello.
Yes, so yeah, Alice, yes, over to you.
Yeah, thank you very much, RD Max, for such an insightful presentation. RD Baden had to be excused for some assignments, so I'll take over from him. We are very grateful for sharing this very important aspect of our work, and thank you very much. So I think we would like to take questions or comments on this presentation. You can either put it on the chat or you raise your hand, and then we would give you audience to either comment or ask your question. So please, if you have a comment or you have a question, you can put it in the chat box and I'll take it from there, or you raise your hand and then we would call out your name, you unmute, and then take it over. All right, so whilst we are waiting for questions or comments, I want to read some of the few comments from our chat box. I'm having comments from a lot of us giving a shout out to RD Max, that is such an insightful presentation. And others are asking if the slides will be shared. I think once you registered, that would be done and you have it in your email. And I think most of the comments are a very deep, insightful presentation. A great job, RD Max, great presentation, a very educative presentation. Okay, I have a question here from Araba. Please, I would like to know if a mild pitting edema around the ankle but not on the feet is also an indicator of protein malnutrition. So her question is that is a mild pitting edema around the ankle an indicator of protein malnutrition? So RD Max, please, you can take that whilst I go through the comment section. Thank you.
All right, thank you so much, Alice. And then thank you for the question. So mostly the indication for protein deficiency is mostly pitting edema. And this pitting edema is mostly around the feet or around the hands, okay, sometimes you may have a bit of that presentation around the ankle area, but for me, it is mostly not too common to see it. And so when you see it, you could also assess for the feet as well, whether the edema in the feet and the hands agrees with what you found in the ankle. Because the ankle area, most times, if you have gout, you can have some inflammation going there. So there could be inflammation which could lead to edema there, but it may not necessarily be related to protein deficiency. So once you check in the feet and the hands and it's pitting and it also agrees with what you found in the ankle, then you can confidently say that this person is likely to have protein deficiency. But like I said, I mean, at the end of the day, your labs will give your final, outcome. So it may just be a suspicion that you have in mind. Then once you do the labs, you want to watch out what is the indication with regards to labs. So they may do an LFT, that's the liver function test, and then you realize that your total protein in the blood is low as well as albumin. And that even further goes on to confirm your suspicion of the edema. So it may or may not, but I would want you to confirm with the feet and the hands as well to see whether it agrees with what you found in the ankle. All right. Yeah, how the Alice?
Okay, thank you very much. So I think the point here is that once it's mild, you just have to go back, look at the other body parts, the other limbs, and keep watching out for it. I think that would also help. Apart from the labs and the other things that RD Max have said, you should generally, we do assessment, reassessment. It should be a continuous process. Once that is done, if indeed it's a edema of protein energy malnutrition, you would get it. There is a hand up, DT. Please, can you unmute and then we hear you.
All right. Thank you very much, RD Max, for a wonderful presentation. My question is, what would be your comments on naturally silky hair as part of your nutrition focused physical examination for texture of the hair and also discoloration? Because some children may present with naturally silky hair. Let's say a child 2 years and above may present with naturally silky hair, but not as a result of malnutrition. Sometimes we may get tricked over here. What will be your comments on this? Thank you.
All right. Thank you so much for your question. So like I said, the nutrition-focused physical findings, there are a lot of contraindications that you are likely to have when you are doing the assessment. So what you need to do is to look out for the differentials. So for instance, there are children, like you said, rightly said, they naturally have this brownish hair. So you can mistake it for a malnutrition when it's not. But one indicator is that they normally also have sparsely grown hair. So they don't have a lot of hair on their head. They are also children genetically by the nature of their genes. They naturally don't have hair as well. So once you cannot confidently tell whether it's malnutrition as a result of protein, you can look out for the other assessment indicators. What is the situation with the eyes? What is the situation with the skin? So most times when the child is severely malnourished, it will reflect in the hair as well. So you don't use one indicator to confirm your suspicion. So you look out for other signs before you can come out to confidently say that I think this patient has other forms of malnutrition. So I think that this hair, which is brownish or sparsely grown or easily pluckable hair, could be a sign of protein or zinc deficiency. And then what you need to do is to ask questions, whether this is how the hair is always like, or the mother has noticed some changes in the hair for over the past few weeks or months. And the parent will be able to give you more information before you come out with your diagnosis. Remember that whatever you do is just to give you an idea of what is ongoing. Then the labs will help you to confirm your suspicion.
All right. Thank you, RD Max. I think now we have a lot of questions in the chat box, so I would take that. Okay. So there is a question on how is the examiner going to measure the depth of pitting edema? Using a rule, how about if a child presents with periorbital edema? Should the examiner poke their fingers into the periorbital region and measure the depth before classifying as +1, 2, etc.? RD Max.
All right, thank you. So the classifications based on the millimeters, sometimes not all these things are practical. It just gives you an idea of how deep the pitting should be. And so most of the things you observe it physically. Okay, so you can have two professionals. One will look at it and think it's moderate, another person will look at it and think it's severe. Whatever it is, you should be able to identify the risks of malnutrition. As to the classifications, as long as you put in your intervention, whether it's moderate or severe, the intervention will be still need to be put on anyway. So in the orbital region, you don't assess for edema there because that area is can cause pain when you are putting your hands and trying to press around that area. So what you do is that you assess for the pitting in mostly at the hands area there, that's at the back of the hands, or you check the pitting in the feet. Those are the areas you can easily identify the pitting. So you don't have to assess in the orbital area because that area is very sensitive and you may end up causing pain to the patient. So the deepness of the pitting depends on how skillful you, the professional, is to be able to see, the differences in the hollow compressions. And so whether some may look at it to be moderate, ones may look at it to be mild, somebody will look at it to be severe, So it's based on practice. As you do more, you get to know better. But these were based on researches that they came out to say that when the compression is about 600 millimeters, then it means it's very deep. And when it's deep, you can easily see. So you don't need to bother so much about whether you now have to use a rule. The most important thing is that you should be able to know whether there's hollow compressions or there's pitting once you are doing the examination.
Okay, so please, a follow-up one is that the orbital assessment, is it clear on a dark-skinned person?
Yeah, so that would be difficult to see, especially when the redness or whatever is not so visible. But one thing you can always look at is mostly it's accompanied with the sunken eyes. Mostly it's accompanied with sunken eyes. So when you see the eyes are falling backwards, and then you put your hand there, maybe you don't make sure your hand doesn't enter the patient's eye, and that could be very discomforting. So with your hand gloves, you gently put your hand in the orbital region to find out whether indeed whether you can feel the bone. Once there's some muscle or fat in there, once you palpate, you feel some bit of tenderness there. When there's no fat or muscle, you can feel the bone. Sometimes you may not even need to look put your hand there. If it's very severe, it's easy to see. It's easy to see. So when one symptom does not give you a clear picture, you look out for others. So sunken eyes could be an indicator of fat loss and as well as protein or energy loss in that area as well.
I think we have a whole lot of questions on edema. That what someone is asking, is it possible to have edema around the body excluding the feet? Let me just put them together so that you just address them as one. Is it possible to have edema around the body excluding the feet? And then another is asking about the difference between edema and gout. I think the last bit on edema is what happened to classifying edema using regions they occur at.
Okay.
And for how long do the dents fail after checking for edema?
Okay. Okay.
Yeah.
So just a minute, I'm writing the questions so that because they are
Okay.
scattered
I
all
think
over here.
it's just in the chat box.
Yes. Okay.
Yes.
So
Yes.
you can have edema, but it's not in the feet. But most times it is very common to have edema within the feet area and within the hands. Mostly it occurs in the extremities. But that does not mean that you cannot have edema in other parts of the body. So you can have edema in the arms. Some people have edema around their thighs. Okay, so you can still assess all that. But what you need to know is that it's not mostly common in those areas. So if you tend to have edema in other parts of the body and it's not in the feet, it's not a weird thing. It is very possible, but most likely you will get it in the feet and in the hands. Yeah, it's very easy to assess that. So for me, if I'm looking out for edema, I would go to those areas before I come to the other parts of the body, because the presentation mostly occurs at the extremities. Then the other question about edema and gout. So gout is when we call it gouty arthritis, or when someone has high levels of purine in the blood, that is causing problems in the joint. So the reason why I brought an issue of gout was in relation to the fact that mostly gout presentation occurs in the ankles. You have inflammation around the ankle, sometimes in the fingers, the tips of the fingers as well. And so mostly you would want to be sure that this particular edema around the ankle is not related to gout. So what I was saying, that if the person has any signs of gouty arthritis, then you want to query that instead of a malnutrition indicator if it's not found in other parts of the body. So it could be used as a differential. So gout is an inflammation or arthritis that would occur. It mostly occurs around the feet area. Okay, so and most of them will have inflammation and redness around that area due to the buildup of uric acid. So when you have high levels of uric acid building up in the blood and it mostly goes to the joint, then you can have some inflammation there. It may not necessarily be edema in the feet. So it's rather better to assess for it in the feet and the hands instead of around the ankle area, because it could be an indication of other conditions such as gout. Then the classifications of edema by regions, yes, that is another way to classify if you think that is what you want to use. There's nothing wrong with that. Yeah, but the reason why I actually chose the classification based on the pitting is that you want to identify whether the edema is of malnutrition origin. Because most of the times you can have a patient who have edema, but the person is not malnourished. It could be an ongoing chronic disease, especially for people who have heart failure. You see that they just have swollen legs, especially some hypertensive patients who present with a lot of edema in the feet. But when you check, the edema is not pitting. So I would prefer to classify it as pitting and non-pitting, so that I'll know whether this inflammation or edema in the feet is coming from a nutrition origin, or it's as a result of the consequence of the chronic disease, or it's an acute disease state. So depending on what you want to use it for, you can decide to know which one to use. Yeah. All right. So I don't know if I have addressed all the questions on this edema.
That's fine. So there is a one bit of it that what do you think of a distended abdomen in a child, not ascites?
Okay.
And then LFT is unremarkable, but the child is malnourished. What do you think?
Yes, so it's possible. That's why I even said that the LFT That's the liver function test. Especially albumin can be high, but the person is not malnourished. It can be low, but the person is not malnourished. So even in certain jurisdictions, it is now said that albumin should not be an indicator for classifying malnutrition. You should look out for other sources before you can confirm your diagnosis. So it is possible that you can have those enzymes elevated in a situation of chronic disease as a result of response to either a liver failure or maybe chronic kidney disease, not necessarily related to nutrition. And that is why your differentials are very important to be able to tell you whether this is possibly from a nutrition origin or it is a medical condition issue. So always watch out for the differential. So it's possible to have low albumin, but this person probably doesn't look malnourished, but you want to correct that. You want to find out why there's low albumin. Is it because there's liver issue? Then you let the doctors come in, or is it because the person is not eating enough protein? Because ideally you should be able to synthesize your albumin if you are eating well. And so you want to look out for the differentials. So ascites in a child, not related to what can I get a question again?
Okay, so is that there is the standard abdomen, but not ascites. That is what.
Okay, I've seen it. It's here. So
okay.
The standard abdomen in a child, but not ascites. Yes. So it is possible. So there are some children who may have the standard abdomen, and one of those presentations we all know is if you are suspecting kwashiorkor. Okay, kwashiorkor can give you a symptom of distended abdomen, but this child is not necessarily having ascites. But you may want to rule out issues of liver failure. So you want to find out the medical history. What is the child being treated for? Could it possibly be that it's protein deficiency that is causing kwashiorkor? Or if there's pain there, you want to find out whether there's an issue with liver. Because when there's liver failure, you can have ascites in the child, and sometimes accompanied by it's accompanied by certain symptoms in the eye. How do you call this?
Jaundice.
Jaundice, yes. So it's accompanied by jaundice. So once there's jaundice and there's ascites, your suspicion about liver condition or issues that has to do with liver should be high. But once those things are not there and you see that there's distended abdomen and you can see visible signs of other malnutrition, then it could possibly be protein deficiency that is causing kwashiorkor. So it's very possible to have that differences. So you will have to be able to know the differentials and come out with what you think is the cause of the problem. So it's not a one size fits all, but always watch out for other problems in terms of the other areas of malnutrition, which will help you know whether indeed your suspicion is right or not.
All right. Thank you very much for the response. We have one. Is there an alternative way, that is preferably physical way of assessing malnutrition that is related to inflammation without labs and then C-reactive proteins? Is there an alternative way of assessing malnutrition related inflammation that is without using the biochemical? That's the question.
All right. So mostly you would want to find out whether there are other chronic diseases. Okay, so you can have a person may have malnutrition, which is related to inflammation related to malnutrition. You want to use, you don't want to use the labs to confirm that. Okay, so you can probably look out for other signs of malnutrition. So the person has inflammation, you assess the inflammation you think is more of malnutrition. So what you want to ask yourself is, are there other signs of malnutrition that this patient is exhibiting? What is the situation in the skin? What is the situation around the mouth area? Does he have sunken eyes? Does he have pale hands? Does he have paleness in the eyes? And all these things, if it's present, then your suspicion can be confirmed. But the labs are very important because it gives you a very an unbiased or a very much objective view of what is happening, because depending on the skill of the person assessing, the person can tell you he has found A, B, C, D. Another person comes and say he has not seen anything. So that is why the more you practice, the more experienced you are, the more you'll be able to identify a macronutrient deficiency as a result of malnutrition. So you can always watch out for other symptoms of malnutrition to be able to confirm that suspicion. But the labs are very important. Your C-reactive proteins, your albumin, but even those ones alone can be high as a result of chronic disease and not necessarily malnutrition. So you want to watch out for your full blood count. What is the situation in terms of your HB and all that, so that it will give you a proper view before you can settle on your diagnosis.
All right, and thank you very much. I think somebody had a contribution that the standard abdomen may also be related to the spleen. So that could also be an issue.
So issues related to the spleen, but the most common one is always the liver disease, where you are now beginning to accumulate a lot of water there. So spleen too as well. Yeah. And then remember your kwashiorkor in children.
Yes. Thank you very much. I think I wanted to also make a comment that the edema might also not be in those lower extremities that we expect. So for patients with neurological conditions or trauma that they are bedridden or for a long time, we should be looking at the areas like the sacral. Sometimes you may even find around the genitals that there is edema, but the feet might not be so. So we really need to take this seriously, that you draw the attention of the other team, because when you don't discover them, they break out and become wounds that you have to manage, and they can even be deeper than a normal burn or so that they can all influence the nutritional status of the patients. So let's take note of that too, that it is not just the face and then the other parts of the body that we have easy access, but the sacral region that is hidden, mostly they might be in diapers and all that. You should make time to check on those areas, and they are very critical, and once they become infected, it can really defeat all that we have put in terms of our nutritional intervention. I don't know if we have other comments. We have put the attendance link in the chat box. Please make sure you complete it. It's very important. We've reposted it severally. Yes, so I don't have any hand up. If we don't have further questions, I think let me go back to the chat box. There was a comment that the best practice of assessment is from the feet. That's somebody's thought. RD Felicia, that's what she puts there. That's but notwithstanding where you are beginning, I think we should ensure that we are observing our safety protocols and wearing gloves, washing our hands well, because you are going to be touching the skin of the patient. It's either you pick it up or you introduce it to the patient. So as we do nutrition focused physical examination of findings, it's critical that health safety of your clients and yourself, you take notes of that. I think I have a question just now. What's the alternative to assessing protein status using labs apart from albumin? RDMAX.
Yeah.
What's the alternative to assessing protein status using labs apart from albumin?
Okay, so mostly using labs in terms of protein. If it's lab, basically you want to look at the total protein in the in the LFT you want to look at the albumin as well, because the total protein, if you are taking less, you have less total protein in your LFT. So these are the two basic indicators that you use in terms of protein. But one thing about these micronutrient assessments is that we don't have labs that would run a panel for you to just pick for vitamin B1, or it's done, but it's not so common in our setting. And so you want to rely more on your physical assessment to be able to confirm your diagnosis. Like for the niacin, for instance, the pellagra on the skin would help you to know. When it comes to the stomatitis, the chelosis, we all know that once those things are there, you know which micronutrients that you are suspecting. Yeah, so it's basically more on the albumin and then the total protein, which is under the LFT, that's the liver function test. Yeah.
All right. Thank you
And
very
then
much.
iron, sorry, full blood counts can also help you. So your HB levels, especially when you have less protein, you are going to start having low blood, because we all know that the iron sources of protein protein sources are also high in iron. So obviously, once your protein is low, you are going to have your HB low, your full, your mean cell volume, and all the other indicators under the red blood cells. So full blood count can also be used. Yeah.
Yeah, thank you. And regarding the protein, the urine can also come in
Yes.
when you measure nitrogen loss.
Yes.
That can also help you to determine protein. So you can use that to find out whether the patient is losing protein or is adequate in terms of what the patient is receiving. So that too can come in handy. They do, if they are doing the urine test and all that, you can ask them to add it. I think with all that you are saying, what is very important here is that we need to work together with the clinicians and all that. With the labs you are talking about, it depends on where you find yourself. We need to work together and see, either you, the nutritionist, or the dietitian, request it. Is it feasible in your facility? If not, then you need to work with the other team members to get these done, so that once the sample is taken, is done, because the labs are very expensive. Most of them are not covered by the health insurance. So we should take note of them, that we don't just say because we've learned this, you go about requesting for labs anytime, but work with the team so that whenever those samples are taken, a whole panel can be done, instead of doing bits and pieces at the expense of the patient. And thank you. I think we have students who are on, who have joined us. Thank you very much for joining. And their concerns are they don't have the allied health PIN. That is very true. Once you are a student and you are not yet done with your program, for now, you may not be given a PIN. But for those that are interns, you have a provisional PIN or license that they've given you. So you can use that. And you should be a registered member of GAND. So this is to remind all students or interns that you should go to the GAND website and make sure that you go through the registration process, so that when you go through this, it becomes easier for you to also get your CPD points. So for the students, you can contact us after the session and we will get back to you. So the link for the attendance, I'll post it again. And I think RD Max, we are very grateful for your insightful presentation. So we've spent so much time, we wouldn't want to take further time. I want to call on one of us to pray so that we can close the meeting. But I don't know if the executives have any word for us. If there is any message for us, yes. Otherwise, we would just say a prayer and then close today's session.
Hello, Audialis.
Hello.
Yes, and I'm here.
Okay.
Yes. So when Audialis was given the introduction, he said today's CPD was the last. So we have a last one next week. We would be looking at medical nutrition therapy for renal diseases. So next week, Wednesday, 4 p.m., we'll send out the poster very soon, maybe by tomorrow, so members are aware. Yes. So this is just by way of information. Next week, Wednesday, we have our last CPD for the year. Yes, and also please, portals have been, CPD points have been uploaded onto our portals. So we should all check our portals and know whether we have all the points necessary for PIN renewal. If we don't, please reach out to the secretariat. Reach out to the secretariat and let us know which CPDs you attended, and are not showing on your portal, so we can work on that as soon as possible. So we'll put the secretariat number in the chat, or I'll mention it so you can write it. 055 802 4661. 055 802 4661. So you contact us and let us know which CPDs are not showing or have not been credited to your portals if you attended those ones. Thank you. Audialis, over to you.
All right. Thank you very much. So let's pray so that we can end today's session. Our Heavenly Father, we are so grateful unto you for today, for this meeting and the knowledge that has been imparted onto us. We want to thank you for the life of our resource person, R.D. Maxwell. May you increase him, that he would keep on imparting even in our profession and beyond, and for the knowledge that we've had. Lord, we pray that you would increase our wisdom and help us to be able to apply it in our practice. We pray that this academy will grow from strength to strength and help us to end the year well. In Jesus' name we pray with thanksgiving. Amen. So have a wonderful evening.